Welcome back to the Remdesivir Files, a COVID-19 chronicle. In this episode, we will dwell into the critical frontline experience of clinicians who administered Remdesivir during the height of the COVID-19 pandemic. We'll explore the protocols they followed, the timing of administration, how the drug impacted hospital stays, and we'll also look at the real-world case reports that helped shape these decisions. Joining us today is Saakshi Sharma. Thank you for joining us.
Thank you for having me. I am excited to share my perspective on how clinicians likely approached the use of remdesivir and how the scientific research helped shape the way this drug was integrated into treatment regimen.
Let's start with the protocols used by doctors when administering remdesivir. Given your research into the science behind remdesivir, what would likely have been the key guidelines clinicians followed when determining when and how to use this drug?
Well, from a microbiology and research perspective, when it comes to drugs like remdesivir, clinical protocols are crucial in ensuring that treatment is administered effectively. Based on the scientific data available during the pandemic, early intervention was one of the most important aspects of remdesivir's protocol. Most protocols were designed with the understanding that the drug was most effective during the early viral replication phase of the disease, specifically before the disease progresses to a hyperinflammatory stage, which leads to severe complications like ARDS, or what is known as acute respiratory distress syndrome, or multi-organ failure. For clinicians, this would have meant identifying patients who had moderate to severe COVID-19, were experiencing respiratory distress, but had not progressed to the point where mechanical ventilation was required. These patients would likely be started on remdesivir early, within the first 7 days of hospitalization, based on trial data suggesting that earlier treatment is associated with better outcomes. Additionally, the timing of remdesivir's administration would likely have been aligned with the progression of the disease. If the viral load was high and patients were showing early signs of deterioration, clinicians would probably prioritize early initiation. A significant part of these protocols would also include the need for renal function monitoring. Since remdesivir can affect kidney function, clinicians would likely have used baseline kidney tests to evaluate whether the drug was safe for use. For patients with the pre-existing kidney issues, the use of remdesivir would have been carefully considered or delayed.
So it sounds like timing really played a pivotal role. How could clinicians likely have accessed the optimal window for administering remdesivir, and what were the challenges they faced in determining when to start the treatment?
Yes, timing was absolutely critical. Clinicians would have needed to evaluate several factors to determine the best time for remdesivir administration. One of the primary considerations would have been the severity of the patient's condition. In the early stages of severe COVID-19 infection, particularly when patients were suffering from hypoxia or low oxygen levels, but had not yet required invasive ventilation, remdesivir would likely have been most beneficial. To assess this, clinicians would have looked at oxygen saturation levels, especially in patients requiring supplemental oxygen. If the patient's oxygen saturation dropped below certain thresholds, it would have been a clear indicator that the disease was progressing, therefore making it more urgent to administer remdesivir. Another key factor clinicians would have used to assess the timing would have been viral load. Research showed that remdesivir targets the virus during its replication phase, so clinicians would likely have relied on viral load tests such as PCR tests to determine whether the patient was still in the early phase of the disease and if remdesivir would be effective in that particular case. CT scans of the lungs could also have been used to evaluate the extent of lung damage, which would have helped in making the treatment decisions. But here's the challenge. COVID-19 was an unpredictable disease. Some patients deteriorated very rapidly, while others showed signs of improvement without escalating to more severe stages. So, for clinicians, there was often an uncertainty regarding exactly when to initiate treatment. Too early, and the potential benefit might be minimal. Too late, and the viral damage could already be significant, reducing the drug's effectiveness. Another challenge was that many patients presented with comorbidities like diabetes or hypertension or chronic kidney disease, to be in particular. These conditions complicated the decision-making process as the drug needed to be weighed against the patient's overall health status. Clinicians had to balance the known benefits of the drug with the risk of adverse events, which meant that sometimes remdesivir wasn't administered as early as protocol might suggest.
That's fascinating. The uncertainty of timing and the need for constant evaluation. Now, let's talk about the impact on hospital stays. What kind of data or observations do you think clinicians would have been looking at to gauge whether remdesivir had any effect on reducing the length of hospitalization?
In clinical practice, the duration of hospitalization is one of the key markers of a treatment success, especially in a critical disease like COVID-19. For remdesivir, the goal was to reduce hospitalization time, ideally by promoting faster recovery. Clinicians would likely have been looking at a variety of factors to assess this recovery time, the number of days it took for a patient to either recover enough or to be discharged or no longer require supplemental oxygen would have been one of the main indicators. In many of the clinical trials and real world studies, remdesivir was shown to have an impact on the time to recovery. For instance, the ACTT1 trial found that patients treated with remdesivir had a shorter recovery time compared to those who received a placebo. In the hospital setting, doctors would have tracked metrics such as oxygen requirements. If a patient was able to maintain oxygen saturation without the need for increased supplemental oxygen or advanced mechanical support, that could be an early sign of recovery. Symptom resolution, such as improved breathing, reduced fever, and less fatigue, would also have been evaluated. In some patients, this might have led to faster discharge, while in others, it may have meant a more stable condition that could be managed with less intensive care. However, the effectiveness of remdesivir in reducing hospital stay was not universal. Some patients, particularly those with advanced disease stages or comorbidities, did not experience a significant reduction in hospital stay length, and these patients might have required longer stays due to complications such as secondary infections, organ dysfunction, or the need for prolonged mechanical ventilation. Despite these variances, it's clear that in many cases, remdesivir helped reduce the severity of illness, which indirectly contributed to shortening hospital stays, or at least preventing the need for more invasive treatments.
It seems like the real world data from clinicians was critical in shaping the treatment approach. Based on your research, what kind of real world case reports likely influenced the way remdesivir was administered? And what insights did these reports provide?
Real world case reports were absolutely essential in refining how remdesivir was used in practice. Early clinical trials provided important control data, but the real world environment presented a wide variety of clinical scenarios. These reports offered critical feedback on how the drug performed outside of the control trial conditions and gave clinicians the flexibility to adjust treatment protocols. For example, case reports in hospital that saw a significant number of severe COVID-19 patients provided a wealth of data on how remdesivir worked in different patient populations. In some cases, moderate patients who received the drug early showed rapid improvement, with oxygen needs dropping and patients becoming stable enough to leave the hospital sooner. In other cases, elderly patients or those with multiple comorbidities showed less benefit, and their cases served as cautionary tales, reminding clinicians to take into account individual health factors when considering remdesivir. There were also instances where clinicians noticed that the patients who were started on remdesivir later in their disease did not respond as well. These case reports likely led to protocol refinements with a stronger emphasis on early administration. On the other hand, there were reports of patients with mild COVID-19 who did not experience significant benefits, prompting some clinicians to reevaluate whether the drug was always necessary for that group. These case reports highlighted the importance of personalized treatment based on disease progression, comorbidities, and the individual patient's response to the drug. By the time more data accumulated, clinicians were better equipped to make informed decisions on when to administer remdesivir for the best possible outcomes.
Thank you, Saakshi, for shedding light on the challenges and considerations clinicians likely face when using remdesivir.
It was a pleasure to contribute to this discussion. The clinical experience of remdesivir use was dynamic, and it's fascinating to reflect on how research and real world data shaped the treatment landscape.
And thank you to all our listeners for joining us on this episode of the Remdesivir Files, a COVID-19 Chronicle. Stay tuned for more episodes as we continue to explore the science behind the COVID-19 treatment journey. Until next time, stay safe and stay curious.